Good morning, good afternoon, good evening, everybody. Welcome to this new IHCH Junior Clubs. Today, we have the pleasure to welcome Dr. Vélez from Antioquia University in Colombia, that is in internal medicine, that is going to present us a very exciting case. We'll be able to discuss after with Professor Mejía, that is in Cornell University in New York. Dr. Vélez is going to present a slide for the next 10 to 20 minutes. Do not hesitate to set your question in the chat during the presentation, and we'll try to address them at the end of the presentation. So please, Dr. Vélez, you can share your screen.
So good morning to everyone. My name is Juan Vélez. I'm an internist from Colombia, and this presentation was made also with Mateo Mejía, which is my mentor in the hematologic field. So this is the agenda for today. We have the clinical case, the question regarding the case, mainly clinical, the literature review regarding the diagnosis, and finally the conclusions and take-home messages from the talk. So this is a 72-year-old man with past medical history of JAK2 positive myelofibrosis, which was diagnosed two years ago before this new clinical presentation. He received hydroxyurea before, currently without any medical treatment and no previous management with JAK2 inhibitor, also hypertension and type 2 diabetes. The chief complaint of the family mainly is that he is not functioning as well as before. The history of present illness is that for several months, the patient was not functioning well, was having a functional decline with weight loss of mainly 20 pounds and increased abdominal girth with some neurologic non-focal signs as confusion. There was no other accompanying symptoms. This is the physical exam. You can see here the vital signs, which were mainly normal. And the patient was alert, but highly disoriented with mild jaundice, was cachectic with chronic ill appearing, with ascites, hepatomegaly, which was palpable 3 centimeters below the costal margin. There was no clear splenomegaly. He didn't have any telangiectasias, asterixis, or no other skin lesions. And for the neurologic exam, there was no focal neurologic deficit, including the cranial nerve exam. For the laboratory test, so we got here anemia, which was macrocytic anemia mainly, mild thrombocytopenia, the white blood cell counts were normal. He had lymphopenia, no eosinophilia. The liver labs showed increased ALK with increased bilirubin and total direct bilirubin. The creatinine was normal, AST and ALT normal. The functioning of the liver, mainly PT and PTT normal. The other test that showed like normal transferrin saturation, ferritin was mildly increased, fibrinogen mildly decreased, aptoglobin normal, and LDH was normal. In the additional laboratory labs additional labs that we did on admission, we found gamma globulin, which was in normal values, IgM, IgA, IgG also in normal values. The subclasses of IgG, here I brought the IgG4, which was 67 milligrams per deciliter. We will see which is the point for thinking in IgG4 disease, and which was mainly normal here. Kappa lambda and kappa lambda ratio 1.4, which showed a normal ratio for these two light chains, and no evidence of monoclonal protein on the SPEP or the immunofixation. The viral tests for hepatitis B, hepatitis C, and HIV were negative. CT was performed at the admission. The main findings were hepatomegaly, as we found in the physical exam, retroperitoneal fibrosis, which was located mainly around the kidneys, and there was some, the radiologist mentioned a sign which was hairy kidney sign, and in the bone marrow and in the iliac crest and pelvis, also in the long bones, there were sclerotic bone lesions, and as you can see here. Here is the sign that is called the hairy kidney sign, which is kind of a retroperitoneal fibrosis involving both of the kidneys. As there was a kind of a suspicion of a malignant disease, FDG PET was done. Also inflammatory diseases. So this is the image of the PET FDG, which mainly showed increased uptake of the retroperitoneal adrenals, and some increase in the bone, which were the places where the sclerotic lesions were, and spleen. Also, there was some effusion in the thorax, and extensive FDG uptake in the lungs, and there was an enlarged liver, which was non-cirrhotic. So with these findings, the first things to do is to ask a clinical question, that is, what is the most probable diagnosis? And I wanted to approach to this case mainly through the way of thinking, okay, what causes retroperitoneal fibrosis, and of the different causes, which one is more fit to the clinical presentation of this case. So we got these 4 options. There are more, of course, that I'm going to talk about, but we have the IgG4 disease, Erdheim-Chester disease, the retroperitoneal lymphoma, or mesenteric panniculitis. So you can think about which one you think it's the most probable option. And here is a little algorithm, I would say, and some of the main causes of retroperitoneal fibrosis and how to distinguish them. So we got the IgG4 related disease, which nowadays it says like 1/3 to half of the cases of the previous idiopathic retroperitoneal fibrosis is this disease, right? And this inflammatory disease, kind of what you see is an increased IgG4 in the blood test. Yeah, the cutoff point is 135 milligrams per deciliter. When you have retroperitoneal fibrosis, it says 60% of the cases of IgG4 related disease after doing the biopsy have an increased IgG4 more than 135. Also, you can see storiform fibrosis in the biopsy. The IgG4 to IgG ratio in the biopsy is increased. The cutoff is more than 40, and you can see also some inflammation of the venules, right? Also infiltration of eosinophils. Clinically, the main thing that kind of helps to differentiate with others, and mainly with Erdheim-Chester, is that it affects the salivary glands, the lacrimal glands, and those places are not common, at least for Erdheim-Chester disease. And also the aortic involvement is usually under the more abdominal aorta, right, under the vessels that go to the kidneys. And Erickson Chester obviously can affect both thoracic and abdominal, but mainly is more abdominal than thoracic. And the Erickson Chester is surrounding the aorta, something that is called the coated aorta, that is not something that we see as common in IgG4. For infections, we got tuberculosis, histoplasmosis, actinomycosis, and depending on of the background of the patient, the epidemiological background, and the different organs that is affected, for example, the lung in tuberculosis, or for example, the pelvic organs in actinomycosis is how we can approach to this. And Erickson-Chester disease, we're going to talk thoroughly of this disease during the talk. So only one thing that I would like to add, and is that it affects the bones, right? And it causes sclerotic bone lesion, which is one of the main differences with IgG4, and the one that I talk about, the aorta. There are some miscellaneous cases. Most of this is miscellaneous, but we got secondary amyloidosis, which could cause this retroperitoneal fibrosis, trauma, surgery, vascular prosthesis related to inflammation. To this process could cause this thing in the retroperitoneum. And one thing that is called the mesenteric panniculitis, which usually the difference is that it's not as usual in the retroperitoneum, but mostly in the mesentery, surrounding the small intestine. And you can see something that is called the pseudotumor capsule, which is a very thin capsule of one millimeter, like kind of surrounding it. There are malignancies that could be solid malignancies, lung, the prostate cancer, gonads, and also some of the lymphoid causes, like lymphomas, both Hodgkin and non-Hodgkin, and also Castleman disease, both localized or non-localized. For drugs and toxins, we got asbestos. The asbestos and tobacco increase the risk of this eightfold. Radiation and medication as ergot medications. Also, there are some things like infliximab, that there are some cases related to that. And finally, if you don't find anything, you would say, okay, this is idiopathic retroperitoneal fibrosis, which usually is 50% to 70% of the cases. So with these cytopenias, with the FGPET, that is really important in retroperitoneal fibrosis to see if there is any malignancy or inflammatory process related to the retroperitoneal fibrosis. There were done 2 biopsies, mainly the bone marrow biopsy, which showed hypercellular bone marrow with increased atypical megakaryocyte histiocytosis and MF3 fibrosis with serous atrophy. And they were not able to classify with this bone marrow specimen the myeloproliferative process, but this was what they found, right? Knowing that the patient had a past medical history of myelofibrosis. With this perirenal biopsy, what we found was that these big cells, basophilic cells, that are typical lymphocytes, with surrounding fibrosis. The same histology was taken to immunohistochemistry. This is for CD68, which was positive, which is for histiocytes. So we got CD68, CD163 positive, CD14 positive, and was negative for CD1 and Langerhans. This is really important because this is what differentiates from Langerhans and non-Langerhans histiocytosis, right? And in the same biopsy, an NGS panel was performed, and what we found was a BRAF B600 mutation with a variant frequency of 11.2%. Also, there were other variants that were found, which was for TET2, two different variants, and KRAS. So with these molecular findings, with the biopsy findings and the clinical picture, we were able to say, okay, this is Erdheim-Chester disease. The diagnosis of this patient is Erdheim-Chester disease. So the next part of the talk, I'm going to talk a little bit of this disease, talking about the definition, the epidemiology, the monoclonal background and molecular alterations, the clinical manifestations, the diagnosis, the treatment in this molecular era, and the prevalence of this of myeloid neoplasm in Erdheim-Chester disease, because we found these variants in the NGS, and also because of the myeloproliferative disease that he had before. So the definition is that this is a rare histiocytic neoplasm. This is a non-Langerhans histiocytosis with diverse clinical manifestations, including localized, life-threatening, multisystemic disease. It's included in the whole classification of myeloid histiocytic and dendritic neoplasm, as you see here in this part of this box, which is from the full classification. The epidemiology, roughly 800 cases have been reported in the literature. 1,500 estimated worldwide diagnosis, mainly. The age is primarily in the middle age, between 20 to 74 years, and the median will be 46 for US data, and for French data will be 56, between 29 and 86, and the male to female ratio is 3:1. There are few big epidemiologic studies. This is one of them, which is an Italic and French publication. And what they did is retrospectively saw the different cases and kind of tried to identify what's the incidence of this disease. And they found that between 2018 and 2020, there was a 0.35 cases per 1 million of people, right? So it's a really uncommon disease. You see the age of diagnosis, 56 to 62, the median, and the predominance of male sex. As molecular background and genetic alterations, the main genetic alteration is BRAF V600E mutation. This is in 50 to 60% of the cases of ECD. So it's a really prevalent mutation. This is a gene that is located in chromosome 7. Is an intracellular serine kinase of the MAP kinase pathway. So you see that first start with RAS, and then RAF, which is the protein of this gene, is activated by RAS, then activates MEK, and finally the R kinase. This is a potent proto-oncogene, and after the mutation, which what does is increase the activation and increase the cell proliferation after the modification of valine for glutamate in codon 600. This increased more than 500-fold the activity of RAF, and is not longer dependent on the activation of RAS, right? It's found in solid tumors, mainly melanomas, 50%, in anaplastic thyroid carcinomas and non-small cell lung carcinomas, and in pediatric low-grade gliomas. And in methodologic malignancies, 40 to 60% of the Langerhans cells, histiocytosis and Erdheim-Chester disease between 60 to 70%, and for hairy leukemia is 100% of the cases where you can find this mutation. So after the identification of this mutation in histiocytic disorders, and now talking of ECD, there is a firm evidence that ECD is a clonal neoplastic disorder that is related to the MAP kinase pathway. After that, there have been a lot of different publications finding different mutations in this same pathway, including the mutation from the BRAF, but different mutations, NRAS, the PIK trait that it's also a molecular pathway where it's related to this pathway too. Also KRAS, MAP2, K1, and others. Besides of mutations, there have been also they have found some that are fusions between BRAF and other genes, and also ALK with other genes. So it's not only mutation, but also fusions that you could see in this disease. And in a study done in 2015, where wide exome sequencing, RNA sequencing, was done mainly in patients with negative BRAF V600E mutation. It revealed that mutation of fusions of MAF kinase signaling were present in 100% of the patients. So this is a really important pathway, molecular pathway for this specific disease, and also their work as really a strong proton coatings. Now talking about the clinical manifestations, we got signs and symptoms that are highly heterogeneous. And these include neurologic signs, include ataxia, dysarthria, cognitive impairment, mood changes. And what you can see is mainly in the posterior fossa, and also in the dura mater also can be affected, showing masses or just lesions in these places, right? For the endocrine disorders, we got endocrine disorders that are related to the pituitary hypothalamic axis. So you got central diabetes insipidus, almost in 50% of the patients. And in the imaging, what you can see is the posterior part of the pituitary is no longer bright, and also the stack is engorged, right? You can see a retroorbital pseudotumor. You could see, obviously in the endocrine, not only the central diabetes, but also all the other axes could be affected, including prolactinemia, right? In the cardiovascular disease, what you can see is you could have affection of the like coating of the aorta. You could see the pseudomass that is usually in the right atrium, right? And also the surrounding material that is around the heart could be engorged, right? In the lungs, you could see something really similar to ILD. And in the kidneys, what you saw, which was a perinephric infiltrates with retroperitoneal fibrosis, the vessels that go through the kidneys, like the arterial, the arteries that go to the kidneys also can be affected, and could cause hypertension, hypogonadism, because also could affect the gonads, and something that is almost always present, that is 95% of the cases, is the long bone pain and finding osteosclerosis in the metaphyseal, in the metaphysis, right? Mainly in the tibia, both distal and proximal. Also in other long bones, but those are the most common ones. And here are some examples of the imaging that we could see. This is a bone scintigraphy, which was the image that we do before we got FDG PET. Still is the gold standard, but the FDG PET gives us the option to know where is the best place to do a biopsy. So that's why we are using more FDG PET, and we can see other things as the retroperitoneal fibrosis. So you can see the uptake in the metaphyses. You can see the osteosclerotic bone lesions, right? And also some here some osteosclerosis in the mandible. The cardiovascular section, which is the coated aorta, you see that there is also perinephric fibrosis with uptake, right? And the atrial pseudotumor. The ILD picture of the disease, where you can find the engorgement of the between the lung spaces. You can see masses. You can see cysts and ground glass opacities. Here we have some examples of the brain imaging, right? Mainly in the posterior fossa, the pituitary, the posterior orbital pseudotumor, and so this is some of the images that we could see. For diagnosis, we already got the clinical, the imaging, and then we got the histopathology and molecular. For the histopathology, what we will see is CD68, which will be positive, CD163, which will be positive. They are marking histocytes, and what says to us that it's not Langerhans is that Langerine and CD1A are negative. And we could find foamy histocytes, fibrosis, central glomerulopathosis, and total giant cells. And we can also with immunohistochemistry see if there is an increased expression of BRAF, right? But the problem with the immunohistochemistry is that the sensitivity goes between 100 and 80%, and specificity between 18 to 100%. So that's where the molecular test come, right? We have the digital droplet PCR and NGS for BRAF, and the other MAP kinases and MAP kinases, and PI3K AKT mutations for we could do it with NGS, and this is more sensitive and specific. That's why we should do it, right? For the treatment, we got the previous treatment that we got the we usually treated this with cytotoxic therapy as cladribine with clinical response of 50%. The interferons also were used with response of 50 to 80%, but this was highly variable depending on the compromise of the disease. Also, some previous tyrosine kinase inhibitors and imatinib and sorafenib, but only 1 out of 7 patients responded. Also, interleukin inhibition as anakinra, tocilizumab, infliximab, but only for mild disease, and corticosteroids. But the thing is that all these treatments had highly variable responses. So here is where molecular error comes. So we have BRAF inhibitors, MEK inhibitors, and combination of both targeting the specific pathway that is affected. So for BRAF inhibitors, we have bemorafenib, dabrafenib, and encorafenib. So we have a trial that was made that is called the BE basket trial, which was a phase 2 basket trial evaluating the response of bemorafenib in non-melanoma BRAF V600E mutated cancers. This included Erdheim-Chester and Langerhans cell histiocytosis. One of the cohorts had these 2 diseases, and of these, 18 patients had ECD and Langerhans cell histiocytosis, and were evaluated with RECIST criteria as the primary outcome and as secondary with PERSIST. The results show that 14 patients could be evaluated for response. 6 out of 14 had a response, one complete, and 5 partial, with a response rate of 43%. But the disease regressed in 12 of 14 patients, and the 12-month PFS was 91%. And we see here that in the table, the patients that had a complete response and patients that had a stable disease were 8 and 5 with partial response. None of them had progressive disease. And this is the same study, but only talking about the Langerhans disease and Ergen-Chester disease. And we can see the main change, or the big change from baseline. Also that patients didn't relapse it or progressed in the swimmer plot. And the progression-free survival that was not the median progression-free survival and overall survival, the median overall survival have not been reached, with progression-free survival of 86% and overall survival of 96% at 2 years for ECD. We got also MEK inhibitors. The main one that is used is cobimetinib, but there are others as trametinib, binimetinib, and selumetinib. And there is this also phase 2 trial, which evaluated the therapeutic potential of cobimetinib in histiocytic neoplasm of any mutational status. The patients were histiocytic disorders with any mutation on only BRAF, and the primary endpoint was the complete response, the response rate, which was the complete and partial response, measured by PET. And CTI MRI by the RECIST. The results, there were 18 patients, 12 with ECD, 2 with LCH, and 2 with Rosai-Dorfman. 2 had mixed histiocytosis. 89% received 2 or more previous therapies. 83% had MAP kinase mutations, 5 with BRAF, 1 with non-BRAF B600, 4 with MEK1, 3 with KRAS, 2 with ARAF. And others. The complete response was 72%, partial response 70%, and stable disease was 6%. No one had progression of the disease, and early early withdrawal because of clinical deterioration, with an overall response rate of 64%. And here we can see the different mutations, the change in SUV, which was huge in most of the patients, and also here the PFS, which the median PFS have not been reached. This is the change in imaging in these patients that were treated with cobimetinib. And there are some new things that they're trying to do. This is kind of the future, and this is the combination of BRAF and MEK inhibitors. It has been used successfully in case reports, and there is an ongoing clinical trial of combining BRAF and MEK in Texas, but still is ongoing. The thing here is that what we have seen in these 2 previous studies is that these diseases are highly sensitive to kinase inhibition, and the doubt is that it's going to change the response rate or something without adding side effects, right? Here is a case report, case series, 3 cases with a patient with BRAF mutant HCD. And what happened is that mainly in the CNS, they didn't respond it, or maybe had an insufficient response on acceptable toxicities. So they combined vemurafenib with cobimetinib. And these are the 3 patients, and we see how the lesion sizes mainly in the brain decreased. Also the ASUV of the different lesions, right? In these 3 patients with the combination therapy. For the end of this talk, I brought the few slides regarding the high prevalence of myeloneoplasm in non-Langerhans cell histiocytosis. This study was made in 2 centers retrospectively. This patient had histiocytic neoplasms, and what they were trying to see is what was the prevalence of myeloid neoplasm and mutations in these patients. And what they found in 198 cases is that myeloid neoplasms were present in 10% of the cases, 7 before ECD, 6 simultaneously, and 6 after ECD. Here we have the different diseases that they found, and I found this on the web. Sorry for this. This is the different difference between the patient that had mild neoplasms and the one that didn't have it. We can see that the mixed histiocytosis was higher. The age, the patients were elder. They had more JAK2 mutations, and also they had the death percentage was higher, and the survival was lower. This is the different mutation that they found. JAK2, TET, and RAS, ASXL1, ADH2, CARL, TP53, and others. Just for closing the case resolution, the patient had a really poor functional status. The clinical status declined and had worsening delirium. And based on the patient's previous wishes, his family declined the management with vemurafenib and elected hospice treatment, right? So the conclusion and take-home message is that it's a clinically heterogeneous disease, is high incidence of suspicion, and that the clinical picture is the key for having the high suspicion of the disease, that the MAP kinase pathway is vital for ECD, that the targeting of MAP kinase pathway is also highly efficacious and sustainable, and the coexistence of myelin mutation is almost 10%. This is not something that is random, right? So the question is maybe the same ontogeny is coming from the same place, these two mutations? And with this, I close my talk on. Thank you, everyone, for listening to me, and I'm open to questions.
So thank you, Dr. Vélez, for this very comprehensive presentation of this rare disease that we are not very used to see when we treat a patient with hematological malignancies. So I don't know if there is some question from the audience, so do not hesitate again to send it in the chat. So first, Professor Mejía, what is your feeling regarding this disease? What are your comments regarding these presentations?
I think, Juan, the highlight that I will say, and as you were saying, Professor Malard, is this is uncommon, right? But if we don't look for it, we won't find it, right? And what we notice is, I think Dr. Vélez did a good point. When you see something so unique as retroperitoneal fibrosis, that should start making you think that something uncommon is going. Many of this presentation, the functional decline, constitutional symptoms, hepatomegaly, they have many common explanations, but it's the association with these uncommon findings, the aortic encasement, the perinephric fibrosis, that is important. And I think it's, it should be always in our mind so we don't miss these cases.
Yeah, now what is the place also, because now we see that there is a BRAF mutation, the MEK mutation. So in your algorithm, some people with some retroperitoneal fibrosis, maybe it could be very helpful also to screen the patient for this mutation, maybe quicker than what we used to do earlier.
Yeah, 100%. I think Dr. Vélez did an excellent proof of concept of how important showing the MAP kinase mutation in this case is as a diagnostic approach, right? So I 100% agree with you. I think the molecular should be part of the diagnostic from the beginning, and we should start thinking about getting tissue not only for seeing the histiocytes, but also start thinking about identifying these recurrent somatic mutations.
Yeah. So we have some question from Dr. Gulderen. So hello, Ezra. So that said that this is a very interesting case. Congratulations. She asked if there is, given the different genetic variation with the BRAF, the MAP pathway, do we have some different clinical presentations based on the different mutation, and does it will affect the prognosis? And of course, the treatment choice, yes, it will impact the treatment choice, but
okay, so thank you, Guldran, for the question. From what I was able to read about the disease and the knowledge that I had for this presentation, well, there was no big difference in the clinical presentation. Any mutation in the MAP kinase pathway could develop this disease, and there is no, at least in the literature that I read about distinction of the mutation and the clinical presentation, right? But something really important that you ask is if there is any influence in the treatment decisions, and I think there is, because if you have a BRAF V600 mutation, you will go straight to using a BRAF inhibitor, mainly the vemurafenib, which is the one that we have for with an RCT, right? But if we have a negative BRAF, and maybe we don't have an NGS panel, we just did a droplet PCR, then we could go safely treating the patient with a MEK inhibitor as cobimetinib, as we showed in the RCT that we had almost 100% response, or at least no progression of the disease, right?
Yeah, that's a good point on what you highlight. This is important to test the patient to have this targeted treatment, because I think it doesn't make sense to do BRAF inhibitors if there is no BRAF mutation. So we need, and this is like in other diseases, we know that in myeloma, we have 5% of patients that have BRAF mutated, and that in some of them, when they relapse several times, we screen for BRAF to give also some targeted treatment. So we are really in some very specialized targeted treatment, and this is very important to screen the patients for that mutations to have some targeted treatments.
Yes, exactly. And the second question is that there is any known mechanism of immune escape specific to ECD astrocytosis? This is a specific question. I don't have an answer. I don't know if Dr. Malard or Dr. Mejía have any highlight or on this specific question.
I think we need to, there's still a lot to learn in ECD, right? And the challenge is the number of cases. And I think it's very interesting how so many different mutations result in a similar phenotype, right? And talking about the importance of one pathway, not only in one disease, but actually in how we see in hairy cell leukemia, how we see in melanoma. All these are driver mutations that result in a very different phenotype in different scenarios, right? So I think the cell of origin, there's many more factors that might come into play here, right? What's the cell of origin? What you were telling them, maybe the microenvironment, there's the process of selection, right? I think it's fascinating the story of this disease, because it has really changed the conception of how we used to see this disease, right? But I think there's a lot to learn, and I think the rarity of this makes it pretty hard. I think if you see all this retrospective cohorts is how we have gathered all this information, and I think that's probably the way to go in the future.
Yeah, I think it's amazing that they were able to do an RCT, because it's just highly. It's weird. It's not something that you see on a daily basis. So it's just amazing that they were able to do it.
Yeah, and I want also to highlight the question regarding the mutation, myeloid mutation that were associated in 10% of the patient, but so far we don't really know if there is a clear correlation. We know also that we have some myeloid mutation, some random in the genome mutation, so really need also to dig further to know if this is very a common pathway, a common mechanism with the same cell that is involved, if this is just that there is some patient that have this very different mutation, but with some two different pathway on two completely different diseases at the end.
Yes.
So I think we're coming to an end. So do you have a final word to say, Dr. Vélez, Professor Mejía?
Yeah, I will. My wrap will be that this is an uncommon disease, but we have to have it in our mind always, and that it have many different presentations. And as it's an uncommon disease, but the presentation kind of will be common, right? Because there are a lot of diseases that cause pituitary damage. There are a lot of diseases that cause neurologic damage. There are different as vasculitis and IgG4 disease that cause also aortitis. So the thing is to have it in your mind as a differential diagnosis, to do the specific biopsy that you need, and the test as NGS or droplet PCR. And also for the treatment, remembering that we are in the molecular era. So we have to go toward the target therapy. And I think this is the main example, a really good example to see that in the neoplasia world, the target treatment is the key to really fight these diseases.
Yeah, thank you. Very clear and very straightforward message for everybody. So we have to think about it, perform the biopsy, and we really need the molecular for the targeted treatments. Professor Mejía?
No, I think that was a great summary. I wanted to thank you for the invitation. I love coming to the IACH Junior Club, and thank you, Juan, Dr. Vélez, for putting this together. I think it was a great review.
So thank you a lot to both of you for being here for this IACH Junior Club, for this really great presentation and this very great meeting. So it will be available after on the IACH website, so we can everybody can watch him at any time. And I will say good evening, good afternoon to everybody, and see you soon for a new IACH initiative. Goodbye.
Thank you all. Bye-bye.